Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our Pediatric Critical Care Fellowship webinar today. We have very special webinar, and also we have very distinguished guest speakers today. And the topic we are discussing, I think, is very attractive, appealing, and very important and pivotal for all of us, because we are going to talk about how to improve our pediatric patients with sepsis and septic shock, how to improve their outcome, how to precisely treat them and manage them in a better way. And we have better guidelines. Nowadays, we have the Surviving Sepsis Campaign 2026 guidelines that was published a couple months ago. And actually, it's very helpful, informative for all of us to precisely and to better treat our patients. So today, we have Dr. Turki Al-Atibi as our panelist. We have Dr. Emily is going to help us also in our moderators and the panelist board, Dr. Balav Batari and Dr. Bassam Al-Bassam, Dr. Raed Sadiq and Dr. Karen Chong is going to be our speakers today. And again, as you know, the story started since several years when the Surviving Sepsis Campaign published the 2022 guidelines. Then a couple months ago, they updated these guidelines, and actually it was a major update. So I talked to Emily Billycoat, who is a co-author not only on the pediatric, but also in the adult section. Mainly, she is an adult ICU physician who suggested and invited Karen Chong to be our today's speaker. So in the 2026 Surviving Sepsis Campaign guidelines, there was 14 international society who gathered to update these guidelines, and they did very extensive review and systematic analysis of the published information, and they graded this information, and they provided updated not only management, but also started from definition, assessment, diagnosis, diagnostic criteria, management recommendation for both adult and pediatric septic shock. And today we are focusing on the pediatric section. Next month, Emily also is going to help us to identify and to do a better teaching and knowledge about how to treat the adult patient with sepsis and septic shock. So they updated the guidelines starting from definition of septic shock. So now the definition is data-driven, and it replaced the old systemic inflammatory response syndrome-based criteria. Also, they emphasized on the organ dysfunction and the tissue perfusion and the clinical trajectory rather than just on the inflammatory marker. So if you see a patient with altered mental status or patient is desaturating, urine output is going down, this means that the tissue is hypoperfused and there is organ dysfunction. So you don't wait for a specific biomarker. And early recognition and the screening is pivotal here. So structural screening tools in the emergency department and in ICU settings is very important, and strong recommendation for rapid triage of patients from low risk, medium risk, and high risk. Also, one of the major changes nowadays is the timing of antimicrobial therapy. So now there is a lot of emphasis to immediately give empiric antibiotic coverage within the first hour. Don't wait to collect culture. You need to be very proactive and very aggressive, starting early management. And strong emphasis was given on also de-escalating of antibiotic once you get the culture and sensitivity results. So don't give just empiric antibiotic for longer time to avoid the resistance. What about fluid resuscitation? Also, they upgraded their guidelines and recommendations regarding use of balanced crystalloid, which is much more preferred nowadays. And you need to start this before you give vasoactive support like epinephrine and norepinephrine in patients with shock, because if you give the vasoactive support without resuscitating your patient first and fill their tank with the IV fluids, probably you could have more serious arrhythmia and side effects. And also they give conditional recommendation to use a point-of-care ultrasound to guide the resuscitation. I think with time we'll have more and more support, and the guidelines will be more clear about using point-of-care ultrasound, which is almost a standard of care nowadays for all of our patients in acute settings. One of the major questions that was raised and always raised is giving corticosteroids in patients with shock, especially with refractory shock. I think we are going to hear about this with detailed information from Karen. Mechanical ventilation using lung protective strategies also is very important, especially in patients with ARDS. So don't give tidal volume of 8 or 10 per kilogram. You just need to be gentle and to use the lung protective strategies. Maybe use a tidal volume 4 to 6. ECMO considered only, and selected patients with refractory cases, especially those who are candidate to receive a transplant. Also, one of the major recommendations that has been changed or focused on in the 2026 guidelines is the post-sepsis care, because studies showed us that about 30 to 40%, so 1/3 of patients with who have ICU stay with sepsis or septic shock, they end up by having chronic health issues. So they need long-term management, they need rehabilitation, they need neurocognitive evaluation and follow-up, and also they need family support. We are going to hear more and more about all of these recommendations and details from Dr. Raed Sadek, from Dr. Karen, and Dr. Balav, with Dr. Bassam and Dr. Emily are going to help us to answer the questions. Again, our moderator, Dr. Turki Al-Atibi, he is a senior pediatric critical care consultant at King Fahd Military Complex. Our first speaker is Dr. Raed Sadek, who is a consultant, ICU consultant in Imam Mohammed bin Saud University. Dr. Karen is a professor of ICU at McMaster University. I think She is Dr. Emily Kulli, works, I think, in the same place. Dr. Bassam al-Bassam is a critical care consultant at King Faisal Specialized Hospital and Research Center. Dr. Balav Batari is Associate Professor of Pediatric at UMass Chin Medical School at USA. A couple of housekeeping stuff here. If you have any question or queries, just feel free to share your question in the QA box. Attendance certificate should be sent to all of you by next week. And if you want also to read the lecture, not only to hear it, you can do this by activating or enabling the show caption option. There is, I think, 30 or 32 languages. So at your earliest convenience, you can choose your own language and you will be able to have the transcription. Again, we are not here to teach you the facts, but we are training your mind to think, because we either think or think. With that, I'm going to let Dr. Bassam al-Bassam to introduce our first speaker, Dr. Raed Sadiq.
Thank you, Dr. Amr. Welcome all to our webinar. So our first speaker is Dr. Raed. Unfortunately, wasn't able to be here, so this will be a recorded lecture. And as Dr. Amr said, he is a consultant in pediatric ICU. He's the head of the division of the pediatric ICU at Care Hospitals. He's also a senior lecturer at Imam Hamad bin Saud University. Well, I'll let Dr. Raed speak. Thank you.
Good day for everybody. It is my pleasure to present my talk in this interesting webinar, and I would like to thank the organizing committee to invite me to talk about this very updated Surviving Sepsis campaign international guidelines for the management of sepsis and septic shock in children 2026. And actually, I am very proud to be a speaker with our distinguished speaker and one of the author, Prof. Karen, who will present very detailed and amazing update. Just to remind all of us about the sepsis definition journey, which started in 1991 with the sepsis 1 version by the first international consensus definition using the SIRS criteria to define sepsis as sepsis, severe sepsis, and septic shock. Then it was updated in 2001 with sepsis version 2 due to limitation of the SIRS definition, and they recommend to broaden the diagnostic criteria using the biomarkers, imaging labs, and reinforced the sepsis continuum using infection, sepsis, severe sepsis, and septic shock, and they emphasized about the early goal-directed therapy. In the 2005, the first Pediatric Sepsis Consensus Congress, which used the pediatric-based SIRS criteria. However, all we know that there is a limitation of the SIRS criteria with low specificity and oversensitivity. Then the new sepsis version 3 in 2016 that used the new terminology, which is the uncomplicated and complicated infection, and very importantly, they used the life-threatening organ dysfunction criteria, which was caused by dysregulated host response to infection, and they used the SOFA score. However, it was adult version, not developed for pediatric data nor validated. And lastly, in 2024, the new updated Phoenix definition for pediatric sepsis, which defines sepsis as infection with life-threatening organ dysfunction, which include 4-organ system model, including the neurological, cardiovascular, respiratory, and coagulation, and they validate and use the Phoenix sepsis score of at least 2 points in children with suspected infection. And they define septic shock as sepsis with cardiovascular dysfunction indicated by at least 1 cardiovascular point in the Phoenix score, and they remove the redundant term, which is the severe sepsis. They concentrate that the cardiovascular points are severe hypotension, lactate more than 5, or the need for vasoactive medication. So in 2026, the Surviving Sepsis Campaign International Guidelines for the Management of Sepsis and Septic Shock in Children was issued, and it consists of a 68-person panel, included our distinguished speaker, Prof. Karen, and actually it was a very huge multidisciplinary team, and the panel was organized into 5 subgroups focusing on recognition and management of infection, hemodynamics, and resuscitation. So I will concentrate on the first 2 topics, and Prof. Karen will concentrate on the ventilation, adjunct, metabolic, immunological therapy, and long-term follow-up. In this very updated guideline, the recommendation were specified as strong or conditional, which was previously referred as weak. In addition, they use in our practice statement, which is intended to describe current variation in care and not meant to construct as recommendation, and the term also good practice statement were developed in accordance with the grade guidance when the panel judged unequivocal benefit or harm. So comparing with 2020 guidelines, there were 20 recommendations new, 13 were updated for clarity and or new evidence, 6 were reviewed but not changed, and 22 were carried forward based on the consensus of the panel that new evidence was not available. Only 3 recommendations were based on high or moderate certainty of evidence. So the first comparison is for sepsis identification. In the old guideline, as I mentioned, they were using the SIRS criteria. However, in the 2026, sepsis is defined as suspected infection with 2 or more points on the Phoenix sepsis score, and evaluate the 4 systems that I mentioned. In the 2020 sepsis definition, they use this redundant term, which is severe sepsis, where it is defined as suspected or confirmed infection in addition to cardiovascular, ARDS, or other 2 organs. However, in the new guidelines, this was removed, and they use only sepsis and septic shock only. So septic shock criteria in the new guideline defined as sepsis with 1 cardiovascular point, as already described. For screening and recognition, the 2020 guideline suggests implementing systematic screening for timely recognition of septic shock and other associated organ dysfunction. However, it was a weak recommendation. In 2026, they mentioned that in children who are acutely unwell, there was insufficient evidence to recommend implementing a systematic sepsis screening, in addition to established clinical protocols for the timely recognition of sepsis and septic shock. However, also they recommend that for children with sepsis and septic shock, the hospitals should implement a performance improvement program, including standard operating procedures for treatment, and it was a recommendation, a strong recommendation. Why is that? Because they found that since the 2020 guidelines, the only pediatric study with randomized allocation to EMR-based sepsis screening or no screening was published, and they found no difference in the mortality or the number of patients progressing to septic shock. Also for recognition and identification, in the old guideline, they were unable to issue a recommendation about using blood lactate values. However, in the new updated 2026 for children with probable sepsis or septic shock, they recommend measuring blood lactate as part of initial evaluation and management, and it was a strong recommendation. The old guideline 2020, they recommend obtaining blood culture before initiating antimicrobial therapy in situation where this does not substantially delay antimicrobial therapy, and was best practice statement. In 2026, no change. However, they add that for children with the probable sepsis or septic shock, there was insufficient evidence to issue a recommendation for or against a routine molecular testing for pathogen detection or identification. How about antimicrobial therapy? In the old guideline, in children with septic shock, we recommend starting antimicrobial therapy as soon as possible within 1 hour, and it was a strong recommendation. And the updated 2026 almost the same, as they mentioned that it should be as soon as possible, ideally within 1 hour of sepsis recognition, and it is a strong recommendation. In the old guideline 2020, with the children sepsis associated organ dysfunction but without shock, they suggest starting antimicrobial therapy within 3 hours. It was a weak recommendation. In the new updated 2026, with probable sepsis without shock, they suggest a time-limited course of rapid investigation, and if concern for sepsis is substantiated, start antimicrobial as soon as possible after appropriate evaluation, ideally within 3 hours, and it is a conditional recommendation. To complete the 2026 updates for the antimicrobial therapy, they recommend that children with probable bacterial sepsis, where timely evaluation is difficult and there may be a delay due to other issue in clinical care, clinicians should consider giving the antibiotics as soon as possible, and this is good practice statement. Children with sepsis and septic shock treated with antimicrobial therapy, they suggest not using Procal routinely to guide the de-escalation of therapy when effective antimicrobial stewardship program are in place, and this is conditional. In addition, for children with sepsis or septic shock with documented bloodstream infection, they suggest that the hospital should implement routine infectious disease or medical microbiology consultation for management advice, and this is conditional recommendation. For children with sepsis or septic shock without documented bloodstream infection, there is insufficient evidence to recommend about the hospital that should implement a routine ID consultation. How about fluid therapy? There is no change from the old guideline that they suggest administering the 40 to 60 ml bolus fluid with 10 to 20 ml per kilo per bolus over the first hour, and titrated to clinical markers of cardiac output, and discontinued if there is signs of fluid overload develop. And it is a conditional recommendation. Also, the old recommendation that if there is no ICU in the healthcare system and with the absence of hypotension, they recommend against giving fluid bolus while starting fluid maintenance, and there is no change carried. The new thing in the 2026 that for children with sepsis and septic shock, there was insufficient evidence to issue a recommendation on the use of advanced hemodynamic monitoring along with bedside clinical signs that has been recommended in 2026. And the new thing is also in the new guidelines that for children with septic shock, they suggest targeting central venous saturation of equal or more than 70% when the central venous axis is available, over not targeting the central venous saturation, and it is a conditional recommendation. Also, the new guideline recommend for patients with sepsis and septic shock to use cardiac and lung point of care ultrasound to guide resuscitation over not using them if the local training and resources allow, and this is a conditional recommendation. How about vasoactive medication? There was old guideline to suggest about using epinephrine rather than dopamine in septic shock. However, the new guideline in 2026 that there was insufficient evidence to issue a recommendation on the preferred use of epinephrine or norepinephrine as first-line therapy in children with septic shock. In addition, the new recommendation that they clearly recommend and suggest to use the vasoactive medication through the peripheral venous line over delaying the therapy until the central venous axis is obtained, and this is conditional recommendation. In addition, the new guideline mention about there is insufficient evidence to issue recommendation about the co-treatment of angiotensin II or methylene blue for septic shock with persistent hypoperfusion despite the use of vasoactive medication. And lastly, for the intubated children with sepsis or septic shock, they suggest titrating supplemental oxygen to target the conservative range 88 to 92 over the liberal target, and this is conditional recommendation. And the old player hydrocortisone, also the new guideline found that there is insufficient evidence to issue a recommendation whether IV hydrocortisone will to treat in such condition. And this is the end of my talk, and thank you for listening.
Thank you so much, Dr. Raed, for this very informative and thoughtful presentation. Again, please, if you have any question regarding this lecture or the upcoming lecture, please feel free to put it in the QA box. Now, Dr. Emily Berricote from McMaster University. She is an adult ICU physician and a great consultant and also a co-author of the Surviving Sepsis Campaign Guidelines, both in adults and children, is going to introduce our second speaker, Dr. Karen.
Yeah, I'm pleased today to introduce Dr. Karen Chung. She is a professor of pediatrics and specifically critical care at McMaster University. She's been involved in this last few iterations of the Pediatric Surviving Sepsis campaign, and she leads a whole research program around improving the recovery of children after a critical illness. So Karen could not be here today, so she recorded her presentation, and we will play that for you now.
Thank you to the organizers for this honor to present at this year's World Institute for Critical Care and Emergency Medicine. Dr. Al-Sadiq has comprehensively outlined what's new with respect to sepsis screening and diagnosis, fluid management, hemodynamic monitoring, and vasoactive management. My section of this talk will focus on what's new on the guidelines, on ventilation, adjunctive and metabolic therapies, immunologic therapies, and long-term outcomes in the 2026 Surviving Sepsis Pediatric Guidelines. First, the ventilation recommendations. Please note that for the management of non-invasive and invasive mechanical ventilation in children with sepsis or septic shock, otherwise not addressed in these guidelines, The panel deferred to the international guidelines on pediatric ARDS, as these are the same. A new recommendation for ventilation management is on the question of whether we should administer oxygen to target specific oxygen saturation levels. The rationale for this debate is that optimal oxygen saturation range to balance the risks of hypoxemia and hyperoxia is unclear. While we understand that hypoxemia is harmful for tissue oxygenation, the exact lower limit for SpO2 for adequate tissue oxygenation is unclear, and hyperoxia has harmful effects on reactive oxygen species on organ function, inflammation, and microcirculation. Furthermore, defining thresholds for oxygen therapy is important, given that this has implications on resources and inequities in care where access to oxygen therapy is limited. Current recommendations from the WHO were to provide oxygen for SpO2 less than 90% or less than 94% in the presence of shock or encephalopathy. The PALIC-2 guidelines recommend SpO2 targets between 92 to 97% for pediatric ARDS. However, these recommendations predate the OxyPICU trial. We identified 4 randomized controlled trials evaluating liberal versus conservative SpO2 targets. These trials included but were not restricted to children with sepsis. 3 trials used greater than 94% as the definition of a liberal SpO2 threshold, and either 88 to 92%, as in the Peters trials, or 90 to 94%, as in the Cunningham RCT, as conservative SpO2 targets. The 4th, which is the COAST randomized controlled trial that was conducted in resource-restricted settings, targeted oxygen to maintain SpO2 between 80 to 91%. Pooled estimates from these randomized controlled trials demonstrated that conservative SpO2 targets was associated with shorter length of stay in PICU and hospital. Lower or conservative SpO2 targets were also associated with decreased duration of mechanical ventilation, but had no significant effect on other duration of organ support at 30 days. There was no difference in mortality with liberal compared to conservative SpO2 targets. Neurocognitive events were rare and were not statistically significant between the 2 thresholds. And this is important to note as the COAST trial SpO2 target was in the range of 80 to 91%. Adverse events, in particular lactic acidemia, cardiac ischemia, acute kidney injury, and critical hypotension or hypoxia were lower with conservative SpO2 targets. One trial also found that the quality of life adjusted years were not different between groups, but there was an overall incremental net monetary benefit at 1 year with conservative SpO2 targets in mechanically ventilated patients. The panel therefore issued this recommendation. For children with sepsis or septic shock following resuscitation, we suggest titrating supplemental oxygen to target a conservative range, i.e. SpO2 target between 88 to 92%, over a more liberal target, i.e. SpO2 of over 94%. Despite a moderate certainty of evidence, the panel issued only a conditional recommendation for the following reasons. 1, it is not clear if this recommendation should apply to children during the acute phase of resuscitation, as the risk-benefit balance of oxygenation may change during resuscitation for sepsis or septic shock. Second, children with severe anemia, hemoglobinopathies, cyanotic heart disease, low cardiac output states, and neurological dysfunction may have different optimal SpO2 targets. Third, SpO2 monitors may be biased towards higher readings in those with darker skin tones, although there is no indication that the benefits of conservative oxygenation differed in darker-skinned children. These inequities or uncertainties require further research that take into account the setting, availability of continuous SpO2 monitoring, and the timing and level of the intervention. Next, the panel addressed the question of whether sodium bicarbonate should be administered to correct metabolic acidemia in children with sepsis or septic shock. Metabolic acidemia is common in patients with sepsis and septic shock, and the use of sodium bicarbonate to counter such acidemia is common but hotly debated. We know that in critically ill adults, resolution of acidemia is associated with improved survival, yet specific administration of sodium bicarbonate for this purpose has not been demonstrated to improve survival, primarily because it does not fix the underlying cause of the acidemia. We did not find any randomized controlled trials in pediatrics, and therefore we relied on indirect evidence from the adult population. The BICAR ICU randomized controlled trial found no statistical difference in mortality with bicarbonate administration in adult patients with severe acidemia. However, there was a potential survival benefit in adults with moderate to severe acute kidney injury and metabolic acidemia. In pediatrics, we found 2 large retrospective studies examining the efficacy of sodium bicarbonate for metabolic acidemia among a combined 7,460 critically ill children. Both these studies were from the same institution using the same hospital database, and so an overlap in patient cohorts between studies therefore could not be excluded. Children with sepsis accounted for only 13.6% of patients in the Liu study, and the proportion with sepsis was not mentioned in the Wang study. After attempts to control for confounding in the analyses, treatment with sodium bicarbonate was not associated with mortality, length of stay, or time to resolution of organ dysfunction. The panel therefore recommended that for children with sepsis or septic shock, there is insufficient evidence to issue a recommendation on the use of sodium bicarbonate for metabolic acidemia. We did describe that in our practice, 7% of the panel members always and 38% sometimes used sodium bicarbonate for children with sepsis or septic shock with metabolic acidemia, while the remaining 55% of panel members rarely or almost never used sodium bicarbonate for metabolic acidemia in this situation. The most common clinical situations in which panel members considered the use of sodium bicarbonate include severe metabolic acidemia with pH less than 7.1, acute kidney injury, and/or hyperchloremia, with concurrent ongoing hemodynamic instability and shock. The 2020 guidelines did not specifically address the issue of fluid overload following resuscitation of septic shock. For the 2026 guidelines, the panel considered that while observational studies have demonstrated fluid overload to be associated with mortality, longer duration of mechanical ventilation, longer hospitalization, and lower health-related quality of life, it was challenging to ascertain a causal effect due to confounding effect that severity of illness is a major driver for fluid overload. We found no interventional pediatric studies that examined the impact of active fluid removal after initial sepsis resuscitation on patient outcomes. We did, however, find an observational study that compared the outcomes in patients who had positive fluid balance to those who had negative fluid balance. The study found that patients with a positive fluid balance had longer PICU and hospital length of stays. However, there was no difference in the rate of organ dysfunction, acute kidney injury, renal replacement therapy, or the duration of mechanical ventilation between the 2 groups. The panel therefore concluded that there was insufficient evidence to issue a grade recommendation on this question. Based on the consistency of harm observed with increasing fluid overload in observational data, the panel issued a good practice statement that it is reasonable to prevent excessive fluid administration, monitor total fluid intake, and consider active fluid removal in the case of fluid overload after hemodynamic stability is achieved. On the question of adjunctive corticosteroids in children with sepsis or septic shock, this continues to be a hotly debated question. the conditional recommendation to not use hydrocortisone for children with septic shock in whom hemodynamic stability can be restored with fluid resuscitation and vasoactive therapy alone remains unchanged from the 2020 guidelines. The statement for children who remain hemodynamically unstable despite adequate fluid resuscitation and vasoactive therapy was updated to clarify that there was insufficient evidence to issue a recommendation to treat with IV hydrocortisone. The reason for this clarification in the 2026 recommendation is that since the 2020 guidelines, there is conflicting new evidence about the efficacy and safety of hydrocortisone use as adjunctive therapy in children with persistent septic shock, with most observational pediatric studies suggesting potential harm. However, a recent meta-analysis that included 45 randomized controlled trials and 9,500 adult and pediatric patients found that corticosteroids probably reduce short-term mortality and increase rate of shock reversal at 7 days in adults. This led to the 2026 adult sepsis guidelines to issue a conditional recommendation in favor of the use of IV corticosteroids in adults with septic shock. However, this meta-analysis that included children found no difference in mortality in children with the use of corticosteroids. We therefore cannot issue a recommendation on IV corticosteroids in children at this point. We await the conclusion of the international trial led by Dr. Kusa Menon in Canada and Dr. Agus in the US that will answer this important question. Sepsis includes a spectrum of immune derangements with severe systemic inflammation, acquired immunosuppression, or both. In children with an immune-suppressed or immunoparalysis phenotype, the question is whether immune stimulants such as GM-CSF or PD-L1 antibodies can reverse immunoparalysis, and there are several large-scale prospective studies underway. Until then, there is insufficient evidence to recommend routine use of immune stimulants in children with sepsis. Children on immunosuppressants, for example, for malignancy or post-organ transplant, are at high risk of sepsis. Immunosuppressant medications may exacerbate sepsis-induced organ dysfunction. There are therefore potential benefits of withholding immunosuppressants to allow reconstitution of the host immune response to combat sepsis. The downside is that the underlying disease may progress or relapse. There is currently no data in children, and we therefore cannot provide a recommendation on tapering or discontinuing immunosuppressive therapies in children with septic shock. We suggest an individualized approach with collaborative assessment of risks and benefits. Hyperferritinemia may be triggered by infections, and in some children with sepsis, hyperferritinemia has been associated with increased illness severity and mortality, suggesting that immune suppression may benefit those patients. However, evidence supporting the use of immunosuppressive therapies in children with sepsis and hyperferritinemia remain limited, and most available data are from small studies at risk of bias, with wide variability of inclusion criteria, treatment protocols, and outcomes. We therefore cannot make any recommendation on the use of immunosuppressants for children with hyperferritinemia. Long-term morbidity and neurodevelopmental outcomes were not specifically addressed in the prior iteration of these sepsis guidelines. The rationale for including this section for the 2026 guidelines is based on increasing evidence of PICU-acquired morbidities, such as weakness, ICU delirium, iatrogenic withdrawal syndrome, and long-term post-sepsis syndrome that is seen in children. What is new in the 2026 guidelines are questions addressing PICU-acquired morbidities and long-term outcomes. The first question in this section is whether the Early Rehabilitation Bundle, also known as the ABCDEF or A2F bundle, which is now recommended to reduce PICU morbidities and optimize short and long-term patient recovery, can be applied to children with sepsis and septic shock. We found no studies specifically evaluating children with sepsis. We therefore reviewed studies that evaluated an early rehabilitation or A2F bundle in the general critically ill pediatric population. We found 16 studies, including 3 RCTs, 6 implementation or before and after studies, and the rest were observational studies. Pooled data from these studies demonstrated that an early rehab bundle was associated with reduced PICU complications such as withdrawal and delirium. Early rehabilitation also reduced the duration of mechanical ventilation by 1 day. The A2F bundle reduced PICU length of stay, but not hospital length of stay. Notably, early mobilization of critically ill children was found to be safe, with very few adverse events reported. The impact of the early rehabilitation bundle on long-term functioning is less clear. 1 RCT and 2 observational studies reported benefits. However, another pilot RCT and 1 observational study showed no effect on long-term physical functioning. We therefore recommended that for children with sepsis or septic shock, we suggest implementing an individualized early rehabilitation bundle during the acute illness rather than not using an early rehabilitation bundle. Up to 1/3 of children who survive sepsis suffer physical, cognitive, emotional, and/or social sequelae that persist for months to years, known as the post-sepsis syndrome in children. As such, there is potential that optimization of post-hospital follow-up could help recovery by screening for and addressing new or worsening post-sepsis sequelae. We therefore ask the questions: should targeted follow-up be arranged to monitor or treat long-term morbidity? And who is at highest risk of long-term morbidity and mortality who require targeted follow-up? We found 4 small randomized controlled trials conducted in the general PICU population. The interventions were primarily psychoeducational tools for parents. This evidence suggests that a structured follow-up program is associated with improved mental health for the child, as well as improved mental health symptoms amongst parents. On the question of what are the risk factors for post-sepsis syndrome in children, this is an area of significant growth in research since 2020, coming out of the United States, as well as long-term follow-up evidence from sub-Saharan Africa, India, Europe, and global epidemiologic studies. This evidence has provided us with important information on the risk factors for poor outcomes in children who survive sepsis. These factors differ according to the setting. In high-middle income settings, the strongest risk factors for post-ICU recovery are as follows: children with pre-existing chronic complex disease and age. Infants are 2 times at higher risk of new progressive medical conditions, while adolescents are at increased risk of neurobehavioral or cognitive sequelae. Factors such as higher severity of illness, increased length of stay, and social vulnerabilities are risk factors for poor post-discharge recovery. In lower middle income settings, risk factors for poor ICU recovery are age less than 6 months, pre-existing child nutrition, lower maternal education, and poorer access to care. Given these were not studies specifically conducted in children with sepsis, the certainty of evidence was deemed insufficient to recommend for or against targeted post-hospital follow-up for children with sepsis or septic shock. We therefore issued a good practice statement suggesting that we screen for risk factors for post-sepsis morbidity, that we educate parents, patients, and families, as well as clinicians on the importance of post-sepsis sequelae at discharge. And thirdly, that we conduct follow-up assessments for new and long-term sequelae following discharge in children with sepsis. I'd like to acknowledge the members and the group leads of the ventilation group, long-term outcomes group, as well as the adjunctive, metabolic therapies, and immune therapies groups who critically reviewed and synthesized the evidence in order to develop these new and updated recommendations for the 2026 Pediatric Surviving Sepsis Guidelines. I thank you all for your kind attention and the opportunity to have presented the new updates for Surviving Sepsis Guidelines today.
Thank you, Dr. Karen and Dr. Raed for this nice presentation. Now we'll go to the question part of this presentation. So I will summarize some of this question. First, the definition shift. How does the 2026 data-driven definition of pediatric sepsis improve clinical recognition compared to the previous systemic inflammatory response syndrome based in criteria, and what is the challenge might arise in this implementation?
Dr. Balab, I think
Emily?
if you would like to answer, or Emily or Bassam.
Yeah, sure. I think that's a great question. So I think how it would change, or what changes we would see, and how that would change our outcomes or management is, I think the SIRS criteria you tend to think in pediatrics is kids with bronchiolitics, or a simple kid who is sick, just has a fever. The heart rate will be high. They can be tachypneic, they can be tachycardic, and even when they are becoming septic, there can be some changes in the white cell count, either leukopenia or leukocytosis. So that usually does not define, and for us to understand whether this patient is septic or is going into septic shock or not, right? So I think taking that criteria out and focusing on the new guidelines, I think from that standpoint, I think it'll be better. And I didn't get the last question. What the continuation of the question was?
The challenge. It is same question, but it's the challenge for implementation.
Yeah, and once we have a patient with septic shock, with the new guidelines, getting a lactate level immediately, and relying on your clinical examination and the point of care ultrasound. I think that becomes important, is because lactate, I'd like to say, is it's not one value. You try to trend the lactate levels. So even if you look at the oxygen delivery and oxygen consumption graph, the lactate tends to rise as the shock progresses. But rather than focusing on one value, it's a trend. But if you have a septic kid who comes in and the lactate is high, let's say 5, that means, I guess, you're dealing with a very, very sick patient. The second would be your clinical examination. I think that's what the new guidelines also focus on, whether it's cap refill, perfusion, to assess that as you are treating the patient. And then using point of care ultrasound. I think there's a question in the end which talks about pico monitoring, but pico monitoring is not usually available in all places. But assessing the cardiac function and seeing if you have someone with catecholamine resistant shock, shock is not getting better. If they have a pericardial effusion or tamponade, or assessing the function, I think generally that would be helpful. I think that's my opinion.
Very nice. I would like
about
Dr.
point of
Turki.
care. You answer.
I would like to ask Emily, because there is a concept in adults, I don't know if this applies to children as well, of normotensive shock. So we don't wait, till we have the patient have profound hypotension, tachycardia, and all manifestation of sepsis, because, the patient or our body have huge capability of compensating, to avoid development of hypertension, but this happen on expense of tissue hypoperfusion and organ dysfunction.
Yes.
So maybe Emily can emphasize on this.
Yeah, I totally agree. I mean, I'm an adult intensivist, but that's definitely something we see in our younger adults, that they compensate until they crash. So I, as a non-expert, I would think that in children, you definitely have to be very proactive. I'll leave the pediatric intensivist to comment on that. Something I wanted to say is, the PICO, why is there no recommendation on PICO? And the reality is we did this guideline in about a year, which is like a big endeavor given the number of questions. But we had to restrict the number of questions. So we prioritized questions that were relevant to most areas of the world. And as Pallav pointed out, there's no, PICO is not available everywhere. It's also a bit more of a niche tool. So we prioritize broader questions for this guideline.
And Bassam, thank you so much, Emily. But Bassam may also be able to try to help us in children because they are mostly healthier before development of sepsis. Maybe adults, especially elder patients, they have several comorbidities, so their immune system, their capability of adjusting, adapting might be less compared to children. Do you see development of normotensive shock? Do you see your children try to maintain normal blood pressure on expense of tissue hyperfusion frequent?
Thank you. Yeah, we see that all the time. I mean, the shock itself is not hypotension. You can have a patient who is hypotensive, but they're not in shock, and most of the time you would have a patient who is in shock, but they're not hypotensive. And so waiting for them to have a low blood pressure would be really, really late. And that's one thing that I think that we need to emphasize is, I mean, like these guidelines, like they help you, diagnose sepsis and they help you manage sepsis. But one thing you want to keep in mind is that you also need to screen for sepsis. So waiting for all the signs to be there might be too late. And so when you have a patient and you might have signs of an infection, having a screening tool to help with that and start treatment early on is probably your best bet, rather than waiting. Like if you wait on the Phoenix criteria or if you wait on other criteria, that might be too late. So the message would probably be, if you have suspicion, start treatment early on, and early antibiotics, and that's probably your best bet.
Thank you.
Yeah. Okay. Correct. That's why sometimes we start peripheral anatropes before even we insert central line. We'll go to the second question about the hemodynamic support. Why do the guideline emphasize early vasoactive support? And previously, 2020 was about epinephrine versus dopamine, and now it is about epinephrine or norepinephrine after the fluid. How does this differ from the prior practice?
I think by default the question goes to Pallav.
That's clear, huh? That's meaning.
Yeah, I'll try to answer that. And Emily and Bassam, you can add. So I think from a practical standpoint, if someone you've started to, so at time zero, when you've recognized, okay, this patient in a state of shock, and then you start your treatment, of course, the goal is to increase oxygen delivery, right? So DO2 and decrease oxygen consumption. So you start them on some form of oxygen, give them fluids, start them on fluids to increase your stroke volume, cardiac output, preload. That would increase oxygen delivery. So at some point, you'll have to decide whether the fluid is helping or not, right? So although the guideline says, okay, 40 to 60 cc's 60 cc's per kilo of fluids, if the heart rate is not coming down a little bit, the blood pressure is not improved, the perfusion is not, getting better, that time you have to decide, okay, am I dealing with a case of fluid refractory shock? And should I start vasopressors early? So I would say, go up to 60 cc per kilo. I think even in practice, if you see any changes in your vitals and the patient is improving, if during that time, you say the patient is not improving that much, then you would probably start vasopressors early, either that is epinephrine or norepinephrine. And I think dopamine, and Emily can, I think, talk more on this, is we've really shied away from using dopamine. Dobutamine, we don't use it in our pediatric patients, but dopamine, small dose, moderate dose, high dose, as you increase the dose, there's more of an alpha action. And these patients, with septic shock, if they're in a state of shock, you do not want a lot of systemic vascular resistance, because that would increase the afterload, and that would, not help the cardiac output. So you start them on low dose epi, and then you can increase the dose, add a second agent or add a third agent. I think that probably answers the question.
There is another question it's mentioned here, and Dr. Karen answered this question, but because it's mentioned again, maybe they missed the point about how much we can tolerate the metabolic acidosis. And the question was, when we to give sodium bicarbonate?
Yeah, so
according to the
rarely is,
recent
I think,
guideline.
we rarely give sodium bicarb. I would say from a practical situation, if you have a patient with septic shock and they have ARDS, the goal is always permissive hypercapnia in those patients, because as long as the pH is 7.2 or 7.25 even, and the carbon CO2, PaCO2 is around like 60s or so, as long as, like I said, the pH is 7.25, you would tolerate that. And the fluids too, we usually tend to start them on acetate containing fluids as maintenance, in the hope that the acidosis will get better as the body, as the shock gets better. But if you're already at a stage of fluid refractory catecholamine resistant shock, and then you're on milrinone, the cardiac function is not good, you check your labs and the patient is profoundly acidotic. So what the number is, I think it's difficult to say. If you are heading towards, okay, I need to cannulate this kid on ECMO, then probably it's okay to give bicarb at that time, because an acidotic environment is always bad. But just a kid with sepsis, septic shock, who's otherwise stable from a hemodynamic standpoint, but the pH is around like 7.2, 7.25, I would really shy away from using bicarb as such.
Yes, there is a question mentioned also about the corticosteroid. Mentioned Dr. Karen, there is no evidence of hydrocortisone, but the question, when we to consider the corticosteroid, especially in pediatrics in refractory shock.
Yeah, so again, that's a very debatable topic. But from practical standpoint, I think if someone is at a place of catecholamine resistant shock, I think it's fine to give them stress dose hydrocortisone at that time. We have a saying in our ICUs, no one should die without getting steroids if they don't make it. But yeah, that's what I would say. If you've already given fluids are not helping, you've started your pressors, either epi nor epi, added some vasopressin on top of that, the patient is on 3 pressors. I think it's reasonable. I don't know. What do you think, Emily, Bassam?
We say the same thing in my ICU. You can't die without steroids. So, and yeah, I'll leave it there.
Yeah.
Okay.
Yeah, I mean, for me, I don't have
Mhm.
anything against steroids per se. I feel like, yeah, if you're on high doses of epi and norepi, you need to use steroids. What else can you do?
Right. I mean, you can have hyperglycemia, but sure, I mean, this probably is for a later discussion, but you can always use insulin and target what your goal target, blood glucose would be. But I think steroids is, not a bad idea.
Yeah.
And
Excellent.
just
So this will be the last question, because we
just to go back,
exceed the
just
1
I have
hour.
one comment.
About, yeah, go
So
ahead, Dr. Bassam.
yeah, just one comment in regards to the bicarb. Just add to what Dr. Palav was saying. It's not that we don't want to give bicarb, but you need to know what the underlying problem is and address that issue. And so if you are just giving bicarb without addressing the cause of the metabolic acidosis, you're not really helping the patient. And like Dr. Palav said, if the patient is significantly acidotic and you feel like the acidosis is going to affect the contractility of the heart, like it's going to affect this patient in a hemodynamic way, you are going to give bicarb. But if the patient is otherwise okay and you're giving bicarb just for the sake of giving bicarb, there's no justification for that.
Yeah, okay, excellent. So we are not treating number, we are treating the patient. Last question about the antimicrobial timing. The guideline mandate that empirical antibiotics within 1 hour. of recognition of their sepsis. In resources limited setting, what the strategy can ensure compliance without compromising the stewardship?
Yeah, I think start antibiotics sooner. If you are having to wait to opt in blood cultures, or spinal tap, UA, urine cultures in these patients, I would say no one would fault you, and I think it's the right idea to give them antibiotics before you opt in cultures if that's going to take time. It's always nice to, get cultures and then start antibiotics, but and also the trend, I think if you know what bugs are relevant in your area of practice, if there's MRSA, I think you can guide your therapy, or if you have a chronic kid who comes in and has grown a organism in the past that you know of, then guide the therapies accordingly. But I think start antibiotics as early as possible, even if you don't get the cultures, I think is the take-home point.
Okay, good. So, Prof. Amr, the floor to you for closing remark.
Thank you so much, Dr. Turki, for this very nice moderation, Dr. Emily, Dr. Bassam, Dr. Palav, and our great speaker, Dr. Raed and Dr. Karen. Very informative, thoughtful discussion, and I think by the end of next month, we'll have another session on how to treat patients, adult patients with sepsis, septic shock. I think it would be on July 27, and Emily is organizing this too. So please stay tuned. All of our today's webinar attendees should receive the certificate of attendance by next week. By tomorrow, all of you should get the recording of this webinar on YouTube. So we'll share with you through the WhatsApp group and the email the recording by tomorrow. Our fellows are going to graduate soon, the first batch, so congrats for all of them. It was very hard work, and they worked very hard for a year, and now this is the time to celebrate and congratulate all of them for successfully passing their pediatric critical care fellowship. We are going to start another wave of fellowship by October this year. So stay tuned for further information. And with that, I thank all of you for attending this session today, and we'll see you in our upcoming webinars. Have a good afternoon, good evening, good night, wherever you are.
Yes.
Bye.
Thank you very much.
Mm-hmm.